It's time for another 3-question warm-up. Let's get going. What enzyme is responsible for tRNA charging? And then what enzyme catalyzes peptide bond formation? So first we have what enzyme is responsible for that tRNA charging. Well, it's aminoacyl tRNA synthetase. And then what enzyme catalyzes peptide bond formation? That's going to be peptidyltransferase. Next question. How does the emphysema caused by smoking differ from the emphysema caused by alpha-1 antitrypsin deficiency? Well, that emphysema from smoking is typically a intra-acinar scenario, and then emphysema from alpha-1 antitrypsin deficiency is a pan-acinar situation. Next question. What are the causes of a transudative pleural effusion? So you got to think about CHF, cirrhosis, nephrotic syndrome, rarely a PE, and then also just good old-fashioned fluid overload. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to be talking about bipolar disorder. In the simplest terms, bipolar disorder is a mood disorder where the individual experiences periods of severely depressed mood and then periods of extremely elevated mood, which is called a manic episode. So they're fluctuating between these two poles on the opposite ends of the mood spectrum, depression and mania. So they're bipolar. Now, I'm sure you already have a decent idea what depression looks like, but you may not have a good understanding of mania. We're going to talk about depression separately, but for now, let's focus on the characteristics of a manic episode. A manic episode is defined as a distinct period of abnormally and persistently elevated, expansive, or irritable mood and abnormally and persistently increased goal-directed activity or energy. So it's not simply the opposite of depression and being super happy. Sometimes mania is a happy mania, but sometimes it's more of an edgy, irritable mania. And then there's the all-important time course with almost any psychiatric disorder. To be considered a true manic episode, this period of elevated or irritable mood and increased energy has to last at least 1 week. Now, this may be disturbing to the patient, but sometimes patients like the way they feel during manic episodes because they feel so productive and they're having a lot of fun. And finally, just like we saw with schizophrenia, the diagnosis of mania requires that this disturbance is severe enough to cause marked impairment in social or occupational functioning, or it's severe enough to require hospitalization to prevent harm to the patient or harm to others, or it has psychotic features. So if the patient becomes so grandiose that he starts dressing like a superhero and going out in the middle of the night to fight crime, he gets himself arrested and loses his job, that might be mania because it's clearly interfering with social and occupational functioning. Or if he starts having grandiose delusions where he thinks he is a superhero and he starts hearing voices telling him to assemble at Avengers Tower, that's psychosis, so that might be mania. Anyway, the diagnosis of mania requires at least 3 out of the following 7 symptoms. And the mnemonic for these symptoms is dig fast. The D is for distractibility. The I is irresponsibility. These individuals seek pleasure without regard for the consequences. They become very irresponsible. They might become sexually promiscuous during the manic episode, or they might blow up at their boss and quit their job, or max out their credit cards and fly away to live at some exotic location without giving any thought to what they're going to live on. Then the G is for grandiosity, which is this inflated sense of self-esteem. They have self-confidence to spare. They think they're the most important, most talented, most intelligent person in the world. Or sometimes it's a delusional grandiosity where they think they are the president, or they think they're a famous actress, or they think they're Jesus. Then the F in dig fast is for flight of ideas and racing thoughts, maybe loose associations. These patients just can't slow down their brains. They're all energy all the time. Then the A is for activity, especially that goal-directed activity. And also A is for agitation. So they might become super productive during a manic episode. And they do their taxes, and they scrub all the baseboards at 3 a.m., then they detail the car, and then they detail the neighbor's car. They just have energy to spare. But sometimes, instead of being productive, this energy just makes them agitated and antsy. They've just got to keep moving, and they just can't sit still. Or if they're one of those angry, irritable manics, and they have all this extra energy, they get riled up about some issue, and they stay up all night writing letters to Congress. So everything about these patients during manic episodes is just over the top, bigger than life. Then the S is for sleep, specifically a decreased need for sleep. These patients may only sleep a few hours at night during the manic episode. They can't sustain that forever, but remember, a manic episode typically only lasts a couple of weeks. So if they just say, all I need is about an hour of sleep every night and I'm good, it could be mania. And then the T is for talkativeness or pressured speech. It kind of goes along with flight of ideas. They're just talking really fast. They've got all these ideas, their mind's racing, and the ideas are just flying out of their mouth. They also tend to talk louder than normal. So again, dig fast is a good mnemonic for all these different diagnostic criteria, and this list comes straight out of DSM-5. Now there's also something called a hypomanic episode, which produces the same symptoms but less severe and usually a little shorter duration. So instead of being on 11 all the time, these patients are on 8.5. But there are two key distinctions between mania and hypomania. So one distinction is that in hypomania, the symptoms only have to be present for at least 4 days, so not a full week, just 4 days. And perhaps more importantly, with hypomania, the expansive mood does not cause that marked impairment in social or occupational functioning. So can they hold down a job? Can they stay out of jail? Can they keep themselves in check just enough that they don't totally alienate their family? If you're so keyed up that you can't work, you can't relate to your spouse, you need to be in the hospital, that's not hypomania, that's mania. But if it's not that severe, there's no overtly psychotic features, then that's probably hypomania. I used to have a patient with bipolar disorder who would only come in sporadically, and it was always, "Hey doc, how you doing? Good to see you. How about the weather?" And we'd always want to talk about some new business he was starting or some big vacation he was planning or whatever. He always had a dozen big projects going on. He had this wild look in his eyes. But he was super positive and super friendly. He was always very eager to do whatever I told him. "You want to check some labs? Sure, doc. Make sure I'm okay. I got to stay healthy. You want us to do a prostate exam too? I know I just had one 6 months ago, but better safe than sorry." You know something's not quite right when anybody is that excited to get a rectal exam. But he was very high functioning. He was running his own business and doing all these other things. So that's hypomania. You can make the diagnosis of bipolar disorder in a couple of different ways. You have to have at least one manic episode or one hypomanic episode plus one episode of major depression. So if you have at least one manic episode, that's called bipolar 1 disorder. With bipolar 1, you're not required to have the depression. Now, generally these patients will have some depression eventually if they haven't had some depression already. But again, you don't have to see them in a depressed state to make the diagnosis of bipolar 1 disorder. They just have to have one manic episode. Then, the other way to diagnose bipolar disorder is to have both a hypomanic episode and at least one major depressive episode. And we call that bipolar 2 disorder. So when you're seeing a patient with depression, it's important to take a good history and see if they've ever had any episodes of mania or hypomania in the past, because if you give antidepressants to a patient with bipolar disorder rather than someone who has the more common unipolar depression, that antidepressant that you're giving them could conceivably push them from depression into mania or into hypomania. There's also something called cyclothymic disorder, which is a milder form of bipolar disorder that lasts at least 2 years. So instead of these big peaks of mania and these deep valleys of major depression, with cyclothymic disorder you have mild hypomanic symptoms and mild depressive symptoms, and neither of these quite meet the criteria for true hypomania or for true major depression. And to be diagnosed with cyclothymic disorder, again, you have to have symptoms for at least 2 years. Now these symptoms don't have to be continuous, and they could have some periods of normal mood in there, but normal mood is going to last only up to 2 months. Generally these symptoms are continuous. So these patients have long stretches of hypomania, long stretches of mild depressive symptoms. Neither symptoms get severe enough to call it bipolar disorder. Next, I want to talk about the treatment of bipolar disorder. So bipolar disorder is typically treated with a mood stabilizer. Lithium is a classic drug used, usually for the more severe cases. But I've also mentioned that atypical antipsychotics like risperidone or aripiprazole or olanzapine are commonly used to treat mania and bipolar disorder. And there are also certain anti-epileptic, anti-seizure drugs that we use as mood stabilizers, such as lamotrigine, valproic acid, and carbamazepine. We don't really know how lithium works in bipolar disorder, but it may be inhibiting the PIP2 second messenger system, the phosphoinositol second messenger system. But the important thing to know about lithium is the side effects. Lithium has a very narrow therapeutic window, so we have to monitor serum lithium levels very, very closely. So lithium can cause sedation and dizziness. It can cause tremors. It can cause arrhythmias like sick sinus syndrome and bradycardia or some heart block. It can cause hypothyroidism or a goiter even without hypothyroidism. It can cause polyuria by blocking the effects of ADH in the kidney. ADH is anti-diuretic hormone and it causes an anti-diuresis. Now we're going to talk about this again in the renal section, but how often do you get to throw down a little renal physiology in a psychiatry lecture? So ADH or vasopressin causes the principal cells of the renal collecting ducts to insert these water channels called aquaporins into the luminal side of the cells so that water can be reabsorbed from the urine and the urine becomes concentrated. So there's less urine volume. So ADH is causing anti-diuresis. But lithium comes in and blocks those aquaporins so that the water can't be reabsorbed and the urine isn't concentrated and the urine volume increases. So lithium leads to polyuria and diuresis. Lithium can actually cause nephrogenic diabetes insipidus. And lithium is also teratogenic. It causes Epstein anomaly of the heart. And we've mentioned that before. 5 points to anybody who remembers the features of Epstein anomaly. The tricuspid leaflets are displaced inferiorly into the right ventricle. There's hypoplasia of the right ventricle and some tricuspid regurgitation or stenosis. And most of these patients have a patent foraminal valley with a right to left shunt. Out of all these side effects, which one is most likely to be seen shortly after increasing the lithium dose? Well, the answer I'm looking for is tremor. Tremor, especially postural tremor, is a very common side effect from lithium. It often occurs when you first start the lithium or when you increase the dose, but it can occur anytime. Since we have a little time, I want to say just a word or two about dissociative disorders. This has absolutely nothing to do with bipolar disorder, but it doesn't really fit anywhere else in the psych section either. There's dissociative identity disorder, formerly known as multiple personality disorder, where the patient exhibits 2 or more distinct identities or personalities. It's going to be more common in women, and it can be associated with sexual abuse. There's something called depersonalization disorder or derealization disorder, where the patient has these persistent feelings of detachment from their own body, from their own thoughts. The name's very descriptive. They feel depersonalized. Or they feel like they're not real, like they're an outside observer watching their life go by. Everything seems like a dream to them. It's not real. And then dissociative amnesia is where the patient either has amnesia for a very specific event or a specific series of events, or they could have a more generalized amnesia of their identity and their personal life history. And this may or may not be associated with a dissociative fugue, where they wander off or have some apparently purposeful travel during which they have no idea who they are. They might even assume a new identity while they're gone. It's very rare, but it's very interesting too. Think about on Breaking Bad when Walter White was stuck in the desert for 4 days or whatever. And then he pretended to have experienced this fugue state by reappearing naked in a grocery store and pretending he had no memory of the last 4 days. Now, where was I? Oh yes, it's time for the end of session quiz. All right, first question. What are the criteria for the diagnosis of mania? So remember the mnemonic DIG FAST. Distractibility, irresponsibility, grandiosity, flight of ideas, activity and agitation, decreased need for sleep, that's your S, and talkativeness or pressured speech. Next, what mood stabilizers are used in the treatment of bipolar disorder? So there's lithium, and then there's some atypical antipsychotics, in particular risperidone, aripiprazole, and olanzapine. And then there are certain seizure medications, lamotrigine, valproic acid, and carbamazepine. And the last question, what are the potential side effects of lithium? So the big ones are, it's teratogenic, so it can cause that Epstein anomaly. It causes polyuria and nephrogenic diabetes insipidus. It can cause arrhythmias, like sick sinus syndrome and heart block. It can cause hypothyroidism, and then it can cause lots of nonspecific CNS things like tremor, that's a big one, and then also sedation, lethargy, and dizziness. That's it for now. I'll see you next time.